Thank you. So, well, my talk is in some way in the same, let's say, topic as Salman talk, but I will deal with the posterior approach with some comment in regard to anatomy and selection of approach. I have been, very much demonstrated the possibilities for anterior approaches by Salman Sharif. And regarding posterior approaches, we have laminectomy, and also we have the so-called microlaminoforaminotomy. This is the technique I'm going to deal with over the next maybe 15 minutes. And this is about the keyhole approach, posterolateral approach, removing some inferior part of the lamina or the superior lamina, some superior part of the inferior lamina, and sometimes some limited medial aspect of the joint, trying to identify the involved root and decompress the root that may be, let's say, compressed by lateral disc herniation in the old terminology called soft disc, or due to foraminal stenosis, due to uncovertebral and or facet joint hypertrophy, as you can see here. But in summary, producing compression of the cervical root. A couple of comments regarding anatomy of the root at the cervical region. This is more for the youngest colleagues in the audience, because unlike the disposition and orientation of the root at the lumbar spine, at the cervical spine, first of all, the mobility of the root is not
Miguel, sorry to interrupt you. Your slide is not moving. Are you moving the slides? Is it frozen on the first slide?
Oh.
And put it in full screen, please.
I am in full screen.
I think
You are on slide number 3.
Move it one by one, Miguel.
Yes, I'm trying to do that. Can you see? This is
Yes.
First slide.
Yes.
Now,
Yes.
Can you see second?
Yes.
Okay. So, well, this is a summary of the approach, the keyhole approach, trying to expose the root, removing some part, as I mentioned before, of the inferior aspect of the superior lamina, superior aspect of the inferior lamina, and sometimes some little part of the medial part of the joint. And these are the two possibilities, the so-called soft disc, and that is a pure herniation, or the phenomenon of foraminal stenosis due to uncovertebral and or facet joint hypertrophy, in any way just producing compression of the root. I was mentioning for the youngest colleagues and regarding anatomy, that is very important, that the mobility of the cervical root is very limited, unlike the mobility of the lumbar root that has a different distribution, different length, and thus can be mobilized more easily. This is where exactly the disc fragment, taking into account the relationship of the disc space and the root, usually is seen. So in the great majority of the cases, we have to look for the disc fragment at this axillary part of the rootlet instead of the upper part of the cervical root. And this is one of the indications. This is a posterolateral fragment compressing the nerve root. This is important to talk about the clinical selection of the patient. Usually, we are talking about a young patient with abrupt onset of radiculopathy, very intense and severe compression of the root due, as in this case, to posterolateral herniation. We can see several fragments of soft disc, pure herniated disc, but top on, left and right, we can see the second possibility for surgical indication, that is foraminal stenosis, as you can see here, or you can see in this other view. So best indication to my mind is the so-called sequestered soft disc. This is one of the posterolateral discs producing nerve root compression, and you can see how this fragment in some instances may even penetrate and disrupture the posterior ligament, the posterior common ligament, so you will find the fragment in between the ligament and dura mater. This is one of the cases of foraminal stenosis. It's very important to look at the anatomy, in this case by means of the CT scan, also MRI, but I mean the anatomy of the foramen, because you have to take into account until which extent, if the operation is related to foraminal stenosis, until which extent you should remove the posterior pseudoapophyseal joints, because you have to take into account that if you remove more than one third of the joint, you will probably solve the problem of the root compression, but you won't solve the problem because you will have pain coming from a joint instability. Sorry, because I'm afraid there are some workers in the hospital working in this particular moment of my presentation. So very important contraindication before this noise is coming back. Contraindication, central disc and myelopathy, and also centrolateral disc. So do not be tempted to try to remove this broad-based disc, because you will have problems regarding spinal cord. This is one of the patient. I'm going to show very quickly a video. Important to mention the clinical selection of the involved root, because sometimes you have not one but two images like that. Usually one is provoking compression, but in cases of some hesitation about, you can do at two level the decompression and be sure that we have contributed to solve the problem of the patient. The surgical technique includes a very easily localization of the space. Usually the patient is operated on in prone position, in my former times in sitting position, but a simple needle may just give some idea of the involved level. And this is a quick video. We are working at the left side, and I will move forward. You have to drill, and you have to use only few instruments. You have to use this ranger, this punch. Very frequently, you have to remove some lateral part of the lamina, some small part of the joint. In some cases, you can see the root and you can see the fragment. Trying to palpate with pencil dissector, rotor dissector. You have sucker, you have aspiration, you have also the pencil dissector, you have a small hook, and these are the instruments you need. You have to palpate, to feel and displace toward the operating field the fragment. Many of them, as you can see here, as sometimes we can see at the lumbar region. Okay, I will move forward. And this is the way you have to free the root. See that in that case, you can perfectly differentiate the nerve component from the sensitive component, usually the nerve one in the lower aspect of the root. Okay, this is the opening, very small. This is the root completely decompressed. And I like to call the attention to this issue, that is this fibrous tissue that sometimes is wrapping around the root, and at the very beginning may just provoke some problems, because in that plane you cannot differentiate the root. If so, you have to coagulate, slightly cut and going just to the medial part, because at the medial part you can find more easily the dural plane, and then just dissecting underneath this fibrotic plane, you can find the root. This is the surgical technique by means of this small opening that can be done by means of microsurgery or endoscopy. I usually do that by microsurgery. This is the summary of the publication, usually pointing out a very good improvement in the radicular pain. Recurrency, unlike lumbar region, is very seldom seen. Complication can be dural tear, motor radiculopathy, and postoperative dysesthesia. It may happen due to the manipulation of the root. So take care when dealing with the root. Do not manipulate so much and take care about the possibility of that kind of complication that usually is not seen at the posterior, at the anterior approach. You can see the series with a large number of cases, and just in comparison with the anterior approach, we have to mention that this posterior root, when indicated and done properly, is solving the problem without getting inside the problem of the adjacent degenerative space. That is a problem very much published in the medical literature after anterior approach. Also, you can see in this image how the adjacent space level can be a big problem after fusion, in that case of 2 levels, in one of our patients. And well, it is something that has been described, the possibility of pseudoarthrosis non-union after anterior approach, irrespective of the material you have used. Talking about arthroplasty, seemed at the very beginning to be a very promising technique, but I have to mention that in our team, we have been using that less and less due to the late fusion and also the possibility of complication. And among them, subsidence. This is not arthroplasty, but this is another material, tantalum, and the possibility of subsidence in osteoporotic spine. And in that case, this is one of my personal cases of pseudoarthrosis after anterior arthroplasty. So if you do the posterior approach, because of the patient has the anatomical and clinical condition for that, you will overcome all the pathology of the hardware related to anterior approaches. Several combinations that are leading to bad results in any way. And I think that posterior discectomy for soft disc has to be taken into account. I had the honor to write this chapter in this book of controversies in neurosurgery, just fighting, if I may say that, against some other possibilities like anterior fusion or anterior artificial disc. And I think this is my last slide, trying to be inside the time frame. Best option in cervical disc disease. Of course, central, lateral, and centrolateral disc have good indication by means of anterior approach, irrespective of the modality. But for lateral and foraminal lateral disc or foraminal stenosis, my conclusion is that we have to take into account the possibility of microlaminophoraminotomy that had obvious consideration from the anatomical point of view. That is the main object of this webinar. Thank you very much for your kind attention.
Okay, Miguel, excellent. Thank you very much. Any questions or remarks? Salman, where are you? Any more with us? Anyone?
I have one question here. Imad, for an osteophyte extremely lateral, do you recommend this technique?
Well, actually not. My main indication, I only do this operation in young patients with posterolateral herniated disc, soft disc and sequestered disc. This is the perfect indication. If the disc is content, by the ligament, is also good indication, soft disc. For osteophyte and foraminal stenosis, this is not my favorite operation. You have to do a CT scan and to see until which extent you should decompress by means of facetectomy to free the root. Sometimes too much leading to posterior instability that provoke lateral pain. So this is not my favorite approach. You can do that. I did hundreds of cases with my former chief, Dr. Arjona, who mastered this technique and taught me this technique. But nowadays, I think we have best option.
Thank you.
Yeah, thank you. Miguel,
Yes.
early 50s, Paul Busey, very, let's say, fundamental neurosurgeon, did the same surgery as you have shown, and he called it mini-invasive keyhole surgery. That was the first time I have seen these terms, and I really enjoyed that very much. And this is really keyhole, actually.
Okay, good. Nice, thank you.
And anyone else?